and I'm the Preferred Vendor Coordinator here at ACAP. Welcome to our latest Education Series webinar. With me today are Doris Stein, she's a partner at Optimity Advisors, Dennis Horgan, Senior Advisor at the same Optimity Advisors, and Akil Shah, he is a manager at Optimity. They will be presenting their webinar titled Improving Outcomes Through Clinical Integration, Opportunities for Payer-Provider Collaboration. And as I hope everyone is now aware, the purpose of the ACAP Vendor Education Series is to share the preferred vendors' vast knowledge on topics that are of interest to ACAP Health Plan members. But before I turn it over, just a few housekeeping items. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP Antitrust Guidelines. The ACAP Antitrust Guidelines can be viewed on the website. We will be recording today's call. We will post the slide deck and recording on our website. You will receive an email after today's webinar when these items are ready to view. And also keep an eye out for additional webinars scheduled throughout the remainder of the year. These webinars will be on Tuesdays and Thursdays during the week. And of course, our list of preferred vendors is on the ACAP website. Look to the column at the right and click on Preferred Vendors. This is a good spot to look at when you're looking at planning to issue new RFPs or are just in general looking for a new vendor. During the call today, you can ask a question at any time. You can do this by typing in your questions in the questions box in the control panel and hit send. All questions will be answered at the end of the call. Now, I'd like to pass it over to Doris, Dennis, and Akil.
Thank you, Ron. Good afternoon, everyone. Very excited to be talking to you today about clinical integration. My name is Doris Stein. I'm a partner with Optimity Advisors. Just a little bit about Optimity. We are an advisory firm, international. We consult to healthcare payers, providers, pharmacies, etc. And we have been focusing the past several years on clinical integration, along with other service offerings, Medicaid, Medicare, etc. And around clinical integration, we've been working with providers on developing value-based contracts, helping them with population health programs, helping them become ACOs, etc., and now have been starting to work with providers and hospital systems around the whole macro myths, which we're going to be talking a little bit about. And we're also working on the payer side as well, working with organizations and payers to understand and help them to working with the providers to help them become clinically integrated as well, and what are some of those value-based contracts. Myself, I have 25 years of consulting and industry experience in healthcare, and again, the last several years I've been focused on helping organizations with Medicaid and Medicare, implementing plans, helping with system integration, compliance, etc. And I've also been working with providers in value-based contracting and becoming clinically integrated. Dennis?
Thank you, Doris. My name is Dennis Horgan. I was formerly the CEO of Catholic Medical Partners, and my background is public health and social and preventive medicine, and I spent almost 18 years working as the Vice President of Healthcare Services for a health plan in which, in my role, we negotiated with dozens of hospitals and over 3,000 physicians. And then the last 10 years, I was president of Catholic Medical Partners. And we had 8 health plan contracts. And in preparation for this meeting, I've probably been involved in 300 to 500 meetings between payers and providers. And I share with you some of my insights, and I look forward to the questions.
Hi all, this is Akil Shah. I've had experience on both sides of the table as well. Spent quite a few years developing clinically integrated networks and organizations. Built several ACOs throughout the Midwest as well as along the East Coast. Most recently have had the opportunity to also help start 3 health insurance companies from the ground up across the country. Have spent probably the better part of the last year working on the payer and provider side around really trying to find some sort of middle ground when it comes to value-based contracting and joint investments in infrastructure development to really drive at the triple aim, and that's some of what we'll be talking about here today.
Okay, thank you, Dennis and Akil. So moving on to the agenda, what we're going to spend the next 45 minutes or so talking with you about is really the market landscape. What are some of the challenges that are being faced today by both the payers and the providers? And what is the impact to the providers and to the payers with the shift to clinically integrated models and value-based payment models? And then we're going to talk a little bit about what are some of the key points for collaboration between the payers and providers. And we always like to sum this up into 4 areas: people, process, technology, and financial. So we're going to give you some examples of what we have seen in organizations around those 4 focal points, and what some of the lessons learned in areas of collaboration between payers and providers. I'm going to hand it over to Dennis to talk about the market landscape.
So let's talk a bit about context and the challenges ahead. From the book Better Care and Lower Cost, it reports some things that you know, but these are striking pieces of information. A quarter of patients report that their doctor had a duplicated test in order to get the proper diagnosis. The average Medicare patient is seeing 7 doctors per year, 5 specialists. Primary care doctors are coordinating care with over 229 other physicians in more than 120 practices. Referral rates, if you see a doctor, have doubled in the past 10 years. Primary care doctors, which are the foundation for both provider organizations and health plans, are experiencing significant burnout. And we have 10 to 30% waste, $210 billion on unnecessary care, and another $130 billion on inefficiency. So these are the problems that we really want to be able to tackle when health plans and providers get together. So it should be no surprise that we have unsustainable costs, fragmentation, lots of waste and inefficiency, and challenges to primary care medicine. So if I look into the past, in my work on the health plan side, I can now see that many of the authorization controls we had in place did little to reduce the cost trend or improve quality. Centralized care management has not solved the problem of coordination of care. Physician profiling, while very important, has suffered from lack of small numbers, lack of proper data from claims, and capping medical expenditures, as evidenced by the sustainable growth rate issues, has not been successful. What we do know is that economic incentives are necessary, but they're clearly not sufficient to bend the cost trend, improve quality, and get the documentation and the proper use of technology. Now I'll hand it back to Doris.
Okay, so I think everybody has heard about the macro MIPS regulation, the proposed regulations that have come out by CMS, and the final rule is going to be published in November. So I'm sure everybody has read the voluminous pages of macro and MIPS, and I know there's a lot of people providing commentary on that, but really what this means is this is a big shift from, as everyone knows, from fee-for-service to fee-for-value, and providers are going to need to figure out what's the best path for them. We've been working, Optimity's been working with several health systems and providers to figure out, and we've also developed a tool to look at what is the best method. If maybe they're already in an alternative payment model, if they're in a PCMH or a bundled payment program, then it's easy, right? Because they can just go down the APM path. But some providers are really struggling about, which path should they choose? Should they go into a MIPS program? Should they join an ACO, et cetera? And it's really, they need to understand if they are going to be going into the MIPS program, what is going to be their scoring and what is going to be their potential penalty or incentive, because I think everybody knows it can go up to 4% penalties, but it keeps increasing as the years goes on, and there can be some incentive as well. And on the payer side, the payers really need to work on supporting these providers to really help them understand where they are in quality, what is their, what's the data. Payers have a lot of data that providers need to be able to help them with quality, as well as providers have a lot of information that payers need as well. So I think every physician, healthcare systems, hospital systems, everyone's trying to figure this out now as to where they are and what path they're going to be choosing. And, when we talk to, it's interesting because we've talked to providers and some providers don't understand, I really have to take one of these paths, and the answer is yes. No one can bow out of this. You either have to go down the MIPS path or the APM path. So interesting to see, what's going to become of this and how everybody's going to react to this. And if you look also, CMS has also just implemented or just has come out with the Medicaid managed care regulations, also called the mega regs. I know CMS doesn't like everyone calling it that, but everybody is calling it the mega regs, and these are the 1,400 pages that came out in May. And it's interesting because we know that 39 states have contracts with managed care organizations. So the payers now are going to have to be looking at these Medicaid managed care regulations, and the mega regs encourage the MCOs to use contractual arrangements to develop and participate in innovative delivery models, and also to be looking at using ACOs, medical health plans, to improve quality of care and efficiency. So not only are the states going through this, commercial health plans, Medicaid, Medicare, everyone is moving to this value-based model. And there's some interesting things in these Medicaid mega regs around new MLR targets. They're set at 85%. There's some different regulations around reporting of data, of encounter data. And then as we talked about, some different things to encourage the MCOs to look at quality, what are their strategies. And also we know that states have already, even before the mega regs have come out, to put some regulations in place for them to encourage or to mandate P4P programs, et cetera. Okay, next slide is, I think I talked a lot about this. Medicaid plans have undergone federal and state mandated shifts, and so there's a lot of things going on. And if you look at this chart, there are already states that have implemented PCMH program, ACO initiatives, et cetera. And I think as we move into 2016, 2018, you'll see that the number of these that are expanding into these programs will continue to grow. Also on the commercial side, we've seen a lot of commercial payers across the country look at shared savings arrangements and value-based contracting with providers. I'm sure some of you on the phone have already entered into value-based contracts if you're payers with providers, and if you're providers, you may have entered into arrangements as well. And again, back to this evolution, and I think what we're seeing payers and providers doing is they're moving towards a full risk model. So short term, maybe some pay for performance, midterm doing some bundled payment programs, shared savings arrangements, and then eventually moving into a longer-term full risk arrangement and capitated payments with payers and with providers. And so what does this mean to providers? So again, this means that providers are going to have to be looking at their practices, their process. What are they doing around case management programs? We've seen a lot. We know that payers have care management programs. Providers are starting to implement care management programs, mobile care management programs. So we need to be looking at what can the payers and providers be doing together to coordinate. What do they need to be doing to reduce volume of readmissions, ER visits, et cetera? A lot of the states are mandating upside and downside risk around some of these programs. And then what are payers and providers doing on the IT side? What are they doing around EHRs, EMRs? How are they integrating data? We've seen when we've worked with these provider systems around ACOs, some of the ACOs that weren't successful, they weren't able to report on the data. So maybe they were implementing and they had the quality scores, but they weren't able to report on the data. So this is going to be key, and we're going to talk a little bit more about this as far as, again, what are the processes, what's the IT, and what's the people infrastructure in place that organizations have around this. And payers, again, as I mentioned, payers are going to have to look at how are they going to be incentivizing the providers to reduce the unnecessary utilization, to look at how are we going to better manage patients or members with chronic conditions. We've talked about the government mandates, the Medicare government mandates, state Medicaids are following with the mega regs. What are some of the quality incentives that payers are mandating? And then what are some of the care delivery synergies that both payers and providers can work towards to achieve that triple aim? And that's some of the things and examples that we're going to be giving, because we're all here to improve outcomes, improve the patient experience, et cetera. Now I'm going to hand it over to Akil that's going to talk about those 4 pillars.
Great. So, when we talk about the framework in terms of evaluating opportunities for collaboration and in terms of evaluating organizations, for the sophistication that they have or need to succeed in these types of programs, we're trying to boil it down to people, process, technology, and at the core of it, financial alignment and financial foundations. And for appropriate partnerships and collaboration for success in these payer-provider relationships, there's really got to be alignment and there's got to be sufficient infrastructure developed to be able to mutually succeed in such programs. So when we talk about people, we're talking about leadership, the types of resources and knowledge and experience folks are bringing to the table, and things like communication, physician engagement, physician leadership. When we talk about process, we're talking about really clinical processes, operational processes, things around standardized care guidelines and how those are communicated, how quality and financial reporting is done and evaluated and peer-to-peer review is conducted, how we're approaching risk stratification, care management, patient engagement, and obviously technology. From a technology standpoint, it all comes down to data. How do we make sure we have the right balance of claims information and real-time point-of-care clinical information to drive decision-making in the point of care, and then care management, risk stratification, and other activities that continuously engage patients along the way. And really at the core of this is how do we align financial incentives to make sure that payers and providers are working towards the same goals, the same benchmarks, and are financially equipped with the appropriate infrastructure to do so. So what I wanted to do here is really, in terms of taking that people, process, technology, financial framework to the next level, we want to boil it down to really 4 key areas of collaboration, 4 major categories. One, when we're looking at true clinical integration in the middle, and that alignment, that's where we start talking about, again, contracting, value-based arrangements, and the way those are jointly developed between payers and providers that will effectively support all of these activities over a set time frame. And really what we're trying to support here is where technology and people start to overlap, IT and analytics. So again, data and analytics are critical and the most powerful lever to be able to drive, again, identifying risk in the patient population, identifying gaps in care, coordinating care, transitions in care, and driving data-based decision-making at the point of care and in ongoing care management activities that'll truly try to make an impact in terms of quality, cost, and patient experience. Population health is bringing together both broader population health programs and chronic disease management, as well as targeted care management, care coordination, and such activities. It's bringing together technology and data to drive effectively how patients are continuously engaged, both by physicians at the point of care, as well as ongoing care managers, care coordinators, and other resources that'll empower patients to really become more engaged in their own care. And one of the things that we'll talk about here is really to ensure from the foundation, as well as ongoing collaboration and success, it's the joint clinical leadership and engagement. And so making sure that the leadership of both payer and provider organizations are aligned with transparency, clear goals, benchmarks, understanding of where each organization sits in terms of ability to take on financial risk, the responsibility to drive some of these clinical activities as well as operational activities to jointly succeed at bending the cost curve. And so we'll spend a little bit of time on some examples in each one of these categories of ways that folks can collaborate. So let's start with financial alignment. At the end of the day, while quality is crucial, while patient experience is crucial, the way these programs through MACRA, the way some of these programs from commercial and Medicaid payers are positioned without any cost savings, it's a tough sell. And in the end, it's about bending the cost curve over time, in addition to quality improvements and some core process redesign and improvements. And so how do we jointly develop a financial business model where payers and providers are aligned to succeed? One thing is looking at this evolution to value-based reimbursement as a transition over a set amount of time. And it's making sure that this transition over a set amount of time is supported by the scaling up of the key infrastructure required within provider organizations, as well as with support from payer organizations to actually succeed. We're seeing the industry move pretty quickly to shared savings arrangements and risk arrangements and bundled arrangements of, just due to the sheer pressure of what's going on in the industry. But a lot of those transitions aren't successful and will not be successful because some of the provider organizations that are trying to deliver care don't have the infrastructure that they need to actually succeed, which ends up being a lose-lose for both the payer and the provider. Again, it's looking at this as a glide path over some time, and we have an illustration on the next slide to talk a little bit about that. But as we talk about this glide path over time, the second point, it's about investing in the infrastructure to drive both provider and patient engagement to actually succeed in this. And so how can we develop the infrastructure over time to help support PCMH type processes and readiness, IT integration and care management capabilities and other infrastructure that's truly going to help bend this cost curve and close gaps in care and drive increased care coordination within organizations. It's not just about getting to shared savings. It's about equipping both organizations to succeed over the long term. And we're seeing CMS, we're seeing a lot of other payers jump into this space where they're actually paying an administrative fee, PMPM, to build the infrastructure over time and then slowly adapt value-based arrangements over time based on that infrastructure that's been developed. We're seeing support for care management and reimbursement for care management activities that are happening within offices. And then lastly, and Dennis will touch on this a bit as well, is jointly developing goals. So utilization, quality, cost goals targets, benchmarks, being able to clearly set ahead of time clear goals over time in a transparent fashion so that both organizations are aligned in terms of what kind of benchmarks we're trying to reach over what amount of time frame. This isn't going to be a drastic improvement immediately. It does take infrastructure, it takes time, it takes the right incentives, and so being clear in terms of where both organizations are trying to go over that time frame is crucial. So just quickly here, talked a little bit about this is the transition to value-based contracts, and really what's required here is infrastructure over time to help support the success in some of these value-based arrangements. When we talk about things like pay-for-performance and some of these programs that have been here over time, it's making sure pay-for-performance and incentives are there to support and invest in key infrastructure and processes that'll help position provider organizations for success. Again, this is turning into an all-payer approach in terms of clinical integration and driving value-based arrangements and value-based care. And so, over time, building in the analytics, the IT, care management to eventually get to a point where, we're truly acting in a accountable care organization type model or a patient-centered neighborhood where hospitals and physician practices and ancillary services in the community and payers are truly integrated in terms of engaging patients and bending the cost curve and making sure that care is coordinated across the continuum. So with that, I'll quickly pass it to Dennis for some of his insights. As we've heard, he's sat in 300 to 500 some payer provider discussions. So just want to touch on a little bit around clinical leadership and engagement.
So I know most of you have had meetings with provider groups, and I would just ask you to pull out the minutes from the last 12 months and go over the agendas and the reports from the meetings and see if you identify areas where cost reductions or variation occurred and whether you were able to make some headway on reducing that unnecessary variation. Look at your quality targets, and if you showed improvements, try to figure out why that happened. Look at your agenda to see if there was a discussion about documentation and coding, and whether the providers were aware of how many dollars may have been left on the table because severity wasn't properly documented. Also look at your minutes to see if there's been administrative simplicity, if in your meetings you've been able to create easier ways for providers and health plans to communicate. If I would say if you're showing success, then keep it up. If you're not, I'd ask you to take a look at these factors. Who's at the meeting? Is your chief financial officer or actuary at the meeting? Is there a medical director from both the health plan, the health system, representative of primary care? Is nursing at the table, and are there process improvement and data people? If this group is not at the meeting, it may be one of the root causes of the fact that you've not been able to make success. In terms of deeper engagement, my experience at the highest level is the CEO, CFO, and the process improvement people need to basically create an annual focus of how the health plan and the provider groups can work together. And this really starts with helping the provider organization understand what the possibilities are for shared savings that will add to their fee-for-service payments. So there needs to be an understanding of the underwriting, the actuarial basis for the premium, targets for both improvement in reducing utilization, lower cost settings, quality gaps identified, and of course coding identified. We were able to basically look at a physician's coding and how it correlated to overall medical expense, and then we provided that information to the doctors, and that made a big difference in terms of their discipline and focus on coding. And then finally, how does this strengthen physician relationships? We used to use a term at Catholic Medical Partners that said the speed of change depends on trust. And we were fortunate in that we were able to establish 8 different contracts with different payers. And those particular goals and objectives that we had to create success in that relationship were really passed on to the doctors in forms of clinical integration goals. So once again, look at your minutes, determine if you have the data on cost, quality, and coding, and then try to basically take those goals and bring them directly to the practicing physicians in the form of clinical integration objectives. So a sample of kind of a delineation of responsibilities. I would say the first thing, and it may be too late for this, is determine if you can get on one EMR system in a community. I think everybody's suffering from the situation where doctors are on 8 to 10 different systems. Begin to look at data aggregation and data governance, making sure that people are putting data in their systems properly. Beginning to look at outlier physician groups or individual physicians. This is our medical director and the medical director of the health plans used to work very collaboratively with physicians that were were outliers, and it made a big difference. Also driving and accelerating PCMH, even though PCMH hasn't necessarily driven cost reductions, it is the beginning of process improvement. Midterm, I would look at a delineation between centralized care management and decentralized. I would focus on looking at how you embed care management in the practices and establishing ways to transfer information on HEDIS gaps and utilization gaps to the physicians. Long term, if you have a RIO, I think you have to figure out how the health plan, the physicians, and your regional health information organization are going to work together. Jointly developing patient quality reports, profiling are all key. And probably finally, as we've said, while financial incentives are important, it needs to really be backed up by infrastructure development and process improvement. So the more you can work together with your payers and providers on practice improvements, building strong human resources, helping people to understand to use technology and proactive medical care. Those, I think, are the ingredients for success. I'll now pass this back to Akil.
And so, what we're trying to get at through delineation of responsibilities here is going back to the core of looking at the core competencies between providers and payers and who's going to be more effective at supporting what types of activities. And we'll touch on that a bit more here. But, if we start with just IT and analytics, if we were in a room and I had to ask folks who's struggling with IT, data aggregation, data integration, as Dennis just touched on, I'm pretty sure 95% of the folks in the audience would raise their hands. And it comes down to making sure that there's a clear, aligned strategy in terms of data aggregation, data sharing, and equipping providers with a balance of, their point of care information that they're collecting in EMRs and EHRs and then medical charts, but supporting that with claims information that's valuable in terms of understanding total cost of care, and vice versa for payers. It's making sure that you're able to supplement claims information with point of care with data from EMRs and EHRs that help you better understand the risk of the patients that you're covering, understand for risk adjustment and other types of programs, risk identification, stratification, ways to develop additional programs to help support the patients in your populations. And so going back to its core, it's what opportunities for collaboration are there for, when we're looking at IT and analytics. It's around data integration and analytics support. And we've worked with clients in developing third-party data repositories that provider organizations can feed data into and payers can take data out of, and vice versa. Just an example of a way data sharing can help empower both the providers when they're doing their higher level quality and gaps in care type reporting, as well as helping them understand what the cost of care is to manage the population. And there's obvious benefits here for payers as well when it comes to understanding the risk of that population. And that leads right into the next point, which is being able to help provide provider organizations with better risk adjustment, risk stratification data, because it's not something that's widely available. It's becoming a little bit more available now through third-party vendors. But again, when we're talking about vendors and data aggregation, there in itself is another obstacle that folks are dealing with. And so anything that payers can do to help equip their providers with better understanding of what patients they're responsible for and what kind of risks we've identified is absolutely critical in terms of being able to engage patients earlier on than just at the point where they walk into your office. And lastly, we talk about technology enablement, and that's both patients and providers. And it's about just making everything data available at your fingertips with your mobile devices and Apple Watches and all of the smart technology that's available. How can we supplement the data that's already available to both payers and providers and help better make more data available to also the patient in terms of understanding their health and engaging them in their health? And so just on the next slide at a high level is just an overview of what we've called driving consumerism, and it's overall digital transformation. It's how do we assess what data we have available at the provider level, at the payer level? How do we digitize it? How do we enhance it and drive analytics out of it, make actionable information out of it, and actually drive patient-provider engagement through that data? And what can we do to work together here to really engage patients, through wearable devices and having information available at their fingertips, as well as appropriately, bringing together claims data and point-of-care clinical data to drive actual clinical improvements here and cost reductions. And then finally, we'll talk about population health programs, and this will range from the use of care coordination and care management programs to broader population-focused programs and patient engagement programs and clinical best practice sharing and this is the crux of the idea of clinical integration in the end. One is when we're talking about core competencies and I'm a patient and I get a call from a care manager or care coordinator from my health plan, am I as willing or open to engaging with them as I would be from a call from my provider organization? And understanding where the better care coordination can potentially take place. Is it within the doctor's office where they know the specialist, they can develop a relationship with the patient? And so really trying to align the concept of care management and making it provider delivered and owned and reducing some of the overhead that may exist at payer organizations, at health plans, where some of those outcomes may just not be there through telephonic care management, or at least stratifying populations and assigning, provider delivered care management and phone-based care management between the payer and provider organizations for various activities. Clinical best practice integration, in our experience in speaking with a lot of payers, there's not much being done nationally around bringing forth best practices from individual practices, from hospitals, from IPAs and ACOs, and really having the opportunity to bring to bear some of what is going on in the marketplace within provider organizations is critical, and it's a level of engagement that providers are looking to engage in, because it's one, an opportunity to sell themselves and demonstrate their successes, but you find that the sharing of best practices between peers is really way more powerful, than a document that a provider organization may get in the mail from payers. And so finding better ways to bring some of those best practices to light and understand what's going on within provider organizations and share that information is just another opportunity to engage the folks that are actually delivering the care. And lastly, it's how can we use the data to actually identify risks and different populations within our membership here to create unique, innovative engagement programs for chronic disease management, transitions in care, other specific populations that'll really give us an opportunity to do better for our patients. And so, this is just an illustrative example of integrated care management model, where some of the telephonic care management can really still happen at the health plan, but maybe on a smaller scale or for a specific population, as opposed to provider delivered care management for those that are higher illness burden, higher risk patients. It's an opportunity to do better at engaging patients. And then lastly, at a high level, just a few types of outreach programs, population health programs, to really focus on specific groups within our membership that are at high risk, that are vulnerable and easy to reach, kind of low-hanging fruit for payers and providers to collaborate on. So with that, I'll pass it back to Doris to wrap up.
So thank you very much, everyone, for joining us today. And if you have any further questions, feel free to reach out to us. I know there's going to be some questions that Ron has. I'm hoping everyone asks a lot of questions now. We're passionate and we love to talk about this topic, and hopefully everyone has learned a few things today. So I'm going to hand it over to Ron for some questions.
Thank you. Our first question, what strategies can payer and provider organizations use to predict and manage financial risk?
Sure. Great question. Probably the most important thing is for the health plans to share the actuarial assumptions with the provider groups. And what I mean is you want to look at admission data, emergency room utilization, readmission data, referral, pharmacy, et cetera, so that the provider groups understand what variation exists, and then for them to look back at their key processes and how they're working together within a healthcare system to tackle some of those problems. As Akil said, very few primary care doctors can tell you how well they treat hypertension or diabetes, if you ask percentage-wise. And for sure, they don't know total cost of care or how, in effect, they contribute to the overall cost and quality of healthcare. So we start with the actuarial assumptions and then move directly to how care is delivered, and then identify solutions to either reduce unit use or unit cost, meaning either decrease unnecessary utilization or get individuals into lower cost settings.
Sure. Okay, our next question. How does an organization create a value-based contract to partner with providers to lower cost trends and improve quality and outcomes?
Another great question. question. We've been working a lot with payers and providers to create shared savings arrangements to really with the goal of improving outcomes, increasing quality, et cetera. And there are multiple methods and ways that payers can collaborate with providers for value-based contracting and value-based arrangements. We've seen examples where payers have supported the providers with mobile clinical teams, mobile IT support. Some have even given some dollars towards that, integrating and enhancing their EMR systems. So there's a lot of different ways that payers can collaborate. But really, what we've also seen is, sometimes there's a lot of duplication as far as care management, IT, et cetera, and it's really valuable for the payers and providers to work together to make sure that they're working together, that there's data transparency, that there's leadership are working together. You heard Dennis mention the examples where the CMOs and others of the payer, both the payer side and the provider side, are holding meetings together with key leadership to best support and figure out how to move forward and how to increase quality, reduce costs, et cetera.
And I think just to add to that, again, it's making sure that both organizations looking to embark on this journey understand that it's a transition over time. When we're looking at value-based arrangements, and whether it's starting kind of elementary fee for service and pay for performance, or administrative fees and support, to shared savings, or moving to bundling, or even assuming kind of shared risk and full risk over time. It's about understanding what capabilities both organizations have to bring to the table, as Doris was touching on, and understanding the appetite for financial risk and the ability to truly actually manage driving quality improvement and cost reductions. And if there is no understanding of a provider organization's abilities to do that, it's a lose-lose. Again, in the end, this program, all these programs are intended, obviously, as an outcome to improve quality and patient experience, but it boils down to cost, and then driving down the cost of care and eliminating the redundancies in care delivery.
Okay, looks like that takes care of our questions for today. I'd like to thank Doris, Dennis, and Akil for their time in presenting an informative webinar today. And I'd like to thank all our attendees for taking the time out of their busy schedule to attend our webinar. I encourage everyone to keep an eye out for webinars for the rest of the year. So thank you very much to everyone.
Thank you.
Thanks, everyone.